Good afternoon everyone and welcome to today's webinar, Systematic and Proactive Care. Thank you all for joining us. Before we get started, I just wanted to share a little bit of information about the Improvement Foundation. We are a national not-for-profit organisation that provides training and consultancy services in the development and delivery of quality improvement techniques and programs. You may have heard of us through the Australian Primary Care Collaboratives program, which we developed and managed for over 10 years. We've worked with thousands of health services around Australia to implement quality improvement initiatives that aim to improve health outcomes for patients or clients, to improve the efficiency and effectiveness of services by streamlining their systems and reducing their costs, and to improve population health more broadly. On the screen in front of you now are the learning objectives for today's session. Please take a moment to review these, because at the end of the presentation an evaluation form will pop up on your screen, and we would like you to think about whether or not these learning objectives have been met, and to provide us with some feedback on how you think we could improve today's session and or provide more information on what other sessions you would like to see in the future. So I'd now like to introduce Prashiba Sabarajadeva. He has been the practice manager of Montague Farm Medical Centre and Mawson Lakes Healthcare in Adelaide for the last 8 years. Previous to that, he had 10 years experience in the corporate sector, working in telecommunications and finance, and he is a qualified engineer, so quite a few arrows in his bow. He was introduced to general practice as he completed his MBA training and worked as a consultant in location intelligence, which involved the use of technology for the benefit of the health and telecommunications sector. Welcome, Prashiba.
Thank you very much, Katie. Hello, everyone. Katie did a wonderful introduction, so I'll get straight into the talk. Good afternoon. As Katie said, I'm a practice manager in Northern Adelaide. We have two practices that I'm going to be talking about today. The two practices are Mawson Lakes Healthcare and Montague Farm Medical Centre. Part of today's talk is also talking about our journey through, one, the primary care collaboratives, and our continuous journey through the improvement cycles that we've undertaken within our practices over the last 8 years. And some of it is for you as practices yourself. You're already probably doing a lot of it, but it's also a way to share our ideas with a larger group as well. One of the mottos of the Improvement Foundation and the Australian Primary Care Collaboratives is share generously, steal shamelessly. And a lot of the ideas that we have developed as well is we've learned from other practices as well. And forums like this give an excellent opportunity to do that. So let's get started. I'll tell you a bit of background of our practices. We roughly have about 14,000 patients, active patients within our practice database. We have age demographics around the 25 to 55, so a lot of younger population. So preventative care and being proactive in the care that we provide becomes an integral part of the way we deliver our healthcare to our patients and our consumers there. We do come from a lower socioeconomic area. Northern Adelaide has probably one of the highest bulk billing rates in Australia, well over the 85% of patients do get bulk billed within Northern Adelaide. Our practices are, we have 12 doctors across the two sites, nurses, receptionists, myself as a practice manager, and other admin staff. All our journey through the practice collaboratives, we have included, we've added the allied health team as well, so your physio, your podiatrist, exercise physiologist. We now have a lactation consultant on site as well, and we have a lifestyle advisor, which I'll talk about a bit later on, and how they fit into providing our systematic care as well. To the next slide. So I'll give you a bit of an overview. I'm going to talk about how we undertake our health assessments and health checks within our practices, looking at how to build the health literacy of your patients, and I'll be talking about SNAP in a bit of detail as well. Later on through the presentation, we'll go and talk about our health analysis tools like PenCS, the Health Atlas, etc. And we'll then finish off with how we get all this working together in a multidisciplinary team environment. And at the end, we'll have a few minutes for questions. So how are you feeling? The idea is your patients come in to your general practices, into your to see your GPs, and they're usually at the left-hand side of the scale. They're when they've got a acute or chronic condition. So they are unwell, they've got their illnesses, and this is when the GPs and your nurses and staff actually deal with a lot of your cases and a lot of your patients within your current workload. But there is another group that we try and target, being a younger age group, is those people that have what I call a false sense of wellness. That's people that are within the comfort zone. They're well, they think that they're well, there's nothing wrong with them, and this is the target group that we try and undertake a lot of our proactive measures with. And this is people that we try and improve the health literacy by giving them the ability to develop the skills to understand their own health. So talking about SNAPs, that's your better nutrition, more physical activity. So then they move to the right-hand side of the wellness scale. So then they're able to maintain a better standard of health for a longer period of time. From the health dollar, we know that when patients come into chronic disease patients come into our practice for secondary and tertiary care, they cost a lot more. And so if we do a bit more effort in the people that are with the full sense of wellness, the primary care dollar is a lot less. Next slide, please. So back in the day, this is going back about 7-8 years ago. This is what my normal day or our staff and GP's normal day looked like. All right, we're run off our feet. We've got so many things on our shoulders. We just don't know which way to go, left, right, straight ahead. We just feel that we're just slugging away and keep things going as best as we can, and we do feel overwhelmed from time. So we need to make a change. We need to make some improvements within our organization. And this is where being systematic in the approach that we undertake becomes a key part. So this is my day, you know, oh my God, what's on my to-do list? And your to-do list as a practice manager, as GPs and nurses, they just get overwhelmed again. You keep adding to your list. Your list never seems to decrease at any stage of your working day. So next slide. So through the journey, what we've done is, it's basically, this analogy is like a juggling act. We've got quite a few juggling balls in the air, and we're trying to keep them all afloat in sync as much as possible. So then, now that we've been able to put in some of the tools that I'm going to talk about, we're now better focused and better organized. So then we could deal with any situation as they come, and there's usually a system or a process in place to deal with that. Next slide, please. So as part of some of you have been part of the Australian Primary Care Collaboratives, and one of our journeys started back in 2009 in one of the first third or fourth wave. So during the Primary Care Collaboratives, we learned a few what we call change principles, and one of those is build and maintain your team. One of the concepts I really got out of that is we recruit our staff for attitude and work ethic. Okay, because we know that if they come to our clinic and join our practices, we could train the skills that we need for them to undertake their day-to-day jobs. So we want the people that have a really positive attitude, really hard-working ethic, and therefore we can train them the skills to undertake their roles going forward. So that's one of the ways that we build our team and maintain it. Next slide, please. As part of the journey that we've been through, early on, and this is a continuous improvement. This is ongoing. So this is clean up your data, and once you clean up your data, you're better able to identify your patients at risk, and that goes without saying. So one of the things that we recurrently do is actually any patients that get not transferred, we inactivate them. Any patient that doesn't attend our practice for greater than 3 years, we inactivate them. Patients with interstate postcodes, we inactivate them. Postcodes that are not, we're in northern Metro Adelaide, so any postcodes outside of 100-kilometre radius, we usually inactivate them. So it's going through the process of cleaning up your database, so then you get a clean data set that you can work with and run reports. And I'll show you later on why that's quite important. For us, it has to be a continuous process. And so for us, we have a receptionist who's also an RN who does this every 3 months. So she'll go in, search these patients, inactivate those patients. And so as it becomes a continuous process and embedded in your routine, the accuracy also improves, and it takes less and less time to do these tasks. Next slide, please. So what happens once you do these changes? Then you can be more systematic, and that's what today's talked about. We know from birth and before birth, antenatal care, till we're 75 or near the end of our life, there is a health assessment or health check that we always undertake. So we used to do, one of our first health checks is vaccination. We used to do the 4-year-old health checks as well, which Medicare stopped about a year ago. We do the APSI health checks. We've got the 45 to 49 and 75 pluses. So this is where being proactive with your patient base and looking at the patients that you do have as best as you can becomes imperative for us. So we know that at different stages of life, there is a health check that we will want to be doing to our patients to make sure that they're looking after themselves and improving their own health literacy. Next slide, please. So one of the original health checks, and a lot of practices would have been doing this from the word go, it's just your normal immunization. So when the kids come into your practices to get their immunization, your nurses and your GPs and ask them about their hearing, their growth, their sleep, their diet, fluid intake, etc. So you're already doing this, talking about the allergies. All right? So we've embedded this as a systematic process within our practice as well, and most of you already do that. Next slide. So this leads on to another opportunistic way of conducting health checks and being proactive with your patient base. We know genes and lifestyle are inherited and are within every family member. So your DNA is part of you and some things you can't change. So understanding your family history becomes a key part in the way you understand your own health literacy as well. Next slide. So what do I mean by this? So when your kids come in for their health checks, for their vaccinations, it's also an opportunity for the nurse or the GP to address the parent's health at the same time. Right? Sometimes it's relevant, and sometimes it's also convenient to do so at that stage. For example, when the mum comes in with the kids to do the immunization, it might be an opportune time for a nurse or your GP to talk about gestational diabetes, preeclampsia, and the impaired glucose tolerance. If the father also comes in, be opportunistic. You know the Red Book has its guidelines for screening as well. So at that opportunity when the kids are there, maybe take the father's blood pressure, talk to them about family history, and discuss there is an opportunity about SNAP as well. So this is the opportunistic way of starting to improve your patient's health literacy as well. Next slide, please. So this is one of the things I learned during working in my practices. is the 5210, which is from the American Pediatrics Association. One of the things that our nurses teach all the students, all the kids when they're coming for their vaccinations, is and teach the parents mainly, is 5 or more fruits and vegetables, 2 hours or less of recreational screen time, 1 hour more of physical activity, 0 sugary drinks. So that is milk and water. All right? So our nurses do this on a regular basis with all the kids that come in for vaccinations. So then we're able to instill the correct information and correct knowledge for the parents as well. Next slide. We know that the RSCGP has preventative activities guidelines within general practice. And this is how we're talking about proactive care with our patients. Not just looking after the kids when they come in for their vaccinations, but look at the adults as well. Now, within busy practices, you might be thinking, hey, you know, where have we got the time to do all this? You don't have the time to do everything, but that's also an opportunity to plant the seed, we call it. So take one item and look at that with the child or the parent, all right? And then when they come back again in 3 months or 4 months or whenever, address another issue at that stage. So that continuity care becomes part of the process as well. Next slide, please. And so what are we trying to achieve? We're trying to help the health literacy of our patients. The better that they could understand what they're eating, as per the SNAPs, you know, reducing smoking, alcohol intake, nutrition, physical activity. So they're able to better understand what they're doing on a day-to-day basis. Therefore, they could prevent some of the chronic conditions later in life or stall it for a bit longer in their life. Next slide, please. So I talked about SNAP a bit. So one of the things is we use it in 2 ways. Like it says there on the slides, opportunistically. That is when the parents come in or the kids come in or patients get taken by one of the nurses before they see the doctor. That's opportunistic. We do also systematically tackle patients as well, and I'll talk about that a bit later on through the doctor's control panel. So we use the doctor's control panel to identify patients that have certain things missing. One of the opportunities that within the practice you have is with SNAPs, especially if there is a patient with a care plan or Aboriginal health assessment, you can charge the 10997 for that education with the nurse. Or if they've got an ATSI health check, a 10987, which is $24. So, and you get 10 of those for ATSI patients. So there are ways to remunerate the nurse's time for that education. Unfortunately, not all patients are with chronic diseases, so you just sometimes do need to be proactive in how you address them as well. Another way is part of the change principles that we discuss is involving just the patients, but also their families in delivering the care. Okay? And it just depends on the patients how they want to engage with their own health care. Some obviously like to do it by themselves, or others with support with other family members and friends. So the idea is building the health literacy and teaching healthy habits so that they can pass it on to the rest of their family and friends as well. Next slide, please. So we're talking about how do we help them improve their health literacy. So there's some easy ways that we do within our practices. One is passive instinct education. That is, we have an info screen in our waiting room. One of the practices, we actually don't have a TV. We do a PowerPoint slideshow, which is our own info screen with our own information that one of our doctors has designed. It's basically about 300-400 slides that just go out throughout the whole day. Facebook is another way that we try and engage with our patients as well. The other part is backup recall questionnaires, and I'll talk to that in a few slides' time. The external support, there are a lot of information on external support out there as well, like the Heart Foundation walking program and Weight Watchers. But we also tackle our patients with active participation with our nurses. So we empower our nurses to go out there and grab the patient out of the waiting room, they think there is something they could address with that patient. And we also run a weight clinic throughout the year as well. Next slide, please. So what do I mean by info screen on the notice board on our TV? So it's basically a large screen TV that with PowerPoint that we've designed information that we get publicly available. It's all out there from recommended sources. All we did was collate it together into an easy fashion to show to our parents, out to our patients throughout the day. Okay, simple to do. So there's other tools out there like Medical Channel and Tonic Health that provide their own TVs and information. You can use that too as well. Next slide, please. Now, back of recalls. A lot of your practices and our practices still do send some letter-based recalls to patients. So one of the ways that we found to engage our patients is use that valuable real estate on the back of those letters. So when you print out your recall letter for, say, for blood test, on the back of it, most people don't put anything on it. So what we've done over the last quite a few years is actually put different health information. So for our general recalls, we would send Australian type 2 diabetes risk assessment. So the patients will receive the letter. They'll read the recall letter for what they received it for, and on the back of it, they'll look at it and go, oh, there's Australian type 2 diabetes risk assessment. Let me fill it out. Oh, I didn't know that if you're male, you're at higher risk. Didn't realize if my waist was this size, I'm at higher risk. Didn't realize my ethnicity caused a higher risk of type 2 diabetes. So you get them to think about their own health and some of the risk factors that can, I guess, project forward in years to come. So the patients will then bring in their recall letter, and what we saw is they'll bring in the back of the recall and discuss that with the doctor. So it's building that conversation with the GPs and your primary care physicians. Other information we've talked about is bowel cancer risk. Next slide, please. Another way that we proactively engage our patients is we run a weight clinic. We run it 4 times a year during the school terms for 8 weeks. We limit each of the clinics to 20 patients. We encourage couples and families to attend. That way, I talked about earlier, is the support, the group support. If they teach another person within the family, they're better able to make those changes around them as well. So a lot of the weight clinic information is on our website. You could share generously and steal shamelessly. The way this clinic runs is the patients will come in. We run twice a week, on a Tuesday evening or a Saturday morning. The patients will come in. They'll see a staff member that does the heights, weights, blood pressure. We have a BMI machine that checks the body fat analysis, does quite a few funky tools and prints out a report. Then they see a lifestyle advisor. Then the lifestyle advisor discusses with them physical activity, diet, and nutrition, a few simple concepts within a 5-minute block. And then they see the GP as well, and then the GP discusses meal plans, any medication, goal setting as well. So they come every week for 8 weeks. So over that 8 weeks, they'll continuously improve. They keep track of their weight and their scores, and within the group setting, they talk to each other, learn from each other, and hopefully they'll make an improvement and change in their lives as well. During these sessions, there's a half-an-hour block where everyone sits together in a group and they listen to a presentation from one of our allied health team. So our mental health clinician during one of the 8 weeks will go and discuss about anxiety and stress about weight loss. It's a simple, broad information that the patients could take on board. For their allied health, it's a better way for them to engage and make sure that their potential patients understand how they could help them through that process. The data we do collect is also forms part of a care research. The next I'm going to talk about is population health analysis tools. So we're talking about PenCS. A lot of you already within your own practice use PenCS. We also use Doctors Control Panel. Previously, we used to use the Health Atlas, and obviously our favorite friend, Facebook, is now the newest part of our population health analysis. Next slide, please. So within our practices, the way we use PenCS is a couple of ways. For our weight clinic patients, we actually run a report for all our obese, pre-diabetic patients, and we send them out an SMS inviting them to attend the weight clinic. Within the SMS is the link to our website, they can get more information on. We run reports during flu season that for our ATSI patients who haven't had a flu vaccinations, we'll send them a letter or give them a call for health checks as well. For our patients with between 40 to 49 with type 2 diabetes risk assessment, we will send them a letter. So we extract a lot of the data, and this is where data cleansing becomes a primary goal within our clinics, is to, the better data we have, the better we're able to target these patients as well. And one of the keys, once you do this, and part of the primary care collaboratives we learned was we must be able to measure it. Any change we do, we must be able to quantify it. And so the information and different campaigns we do, we actually quantify it, and record the data. So then we feed this back to our staff on the progress. So to show an improvement is making a difference, we should be able to have a baseline and see what the improvement is in 2 weeks, 3 weeks, 2 months, etc. So then the staff as well know that the effort and hard work they're putting in is making a difference. And I'll talk to you about that a bit later on. Next slide, please. So this is what I mean. So from our campaign for targeting our 40 to 49-year-old diabetes health assessment at-risk group, you can see that our campaign or our efforts, our systematic efforts have made a difference. And we can see a big spike in our graph. Now, you could see the purple line in the graph. That's where the 4-year-old health checks is starting to die off since that program has ceased. So then we made an effort at the 40 to 49-year-old. Next time, we could address another group. So then the green line's the 45 to 49. Maybe we'll target that next time. That way you can be proactive and systematic in the way you approach it. So let's look at the 45 to 49-year-old patients. So in PenCS, you could actually extract that information. You could run a report. When we did this slide, there were 659 patients at that time with that data set that didn't have a 45 to 49-year-old health assessment done. It's as simple as running that report, you know the number, double-click on it, and it tells you, we'll block it out, but the real data. These are the patients that haven't had a 45 to 49-year-old health assessment done. So this is a way to either extract it to a mail merge or send them an SMS and send them a link to your website so where they can get more information on why a 45 to 49-year-old health assessment is beneficial to them. This is being systematic in that approach. The Doctors Control Panel. This is a wonderful tool, and I'm a big fan and advocate of the Doctors Control Panel. It only works for best practice and medical director at this stage. So we use that to not just for our SNAPs, but health assessments for chronic disease patients and identify other risk factors as well. So it works in a simple fashion, like a traffic light. Green means it's within the recommended time frames, or it's within the Red Book guidelines. Red means it's out of time frame, so it's maybe 2 years overdue, but also outside of Red Book time frames. So what I mean by is if your HbA1c is 10, a recommendation is less than 7, so it'll be red even though you had the test done a week ago. Okay. Orange means, yep, it's overdue or it's outside, marginally outside of Red Book conditions. So it's not something that you have to tackle right now. So when we open up in a real environment, when we open up Mr. ZZ, one of our test patients, it just pops up in the dashboard. It doesn't pop up as big as this. This is just to show you an idea that, to enlarge it to show you for the presentations, but it's a lot less obtrusive. And it just gives you a quick snapshot of that patient for the GP, for the nurse, or the front desk staff. Now, one of the keys to understand is that from this snapshot, our nurses could say, well, hey, this person hasn't had his BMI done for a while, potentially update that, or this person hasn't had his asthma PIPs have been built, so maybe book them in for an asthma action plan or care plan, or get a spirometry done for that patient as well. So then the doctor can book that in for another visit. This is a good way of seeing that information, and this information is just sucked in from medical director, from our clinical software, and our billing software as well, and it lists it all there in a dashboard fashion. Next slide, please. The other form of, I guess, health analysis is the social health atlas. I'm not too sure if any of your practices still use that or have that. It's been a while. The Medicare locals, and before that, the division general practice used to do it. We still have ours. It's a couple of years old, but it's a good way to understand your patient database in a map fashion. So they suck out all your data, they put it in nice maps addressing your postcodes where your majority of your patients come from, their highest risk factors. They'll compare it to the other practices in your area, so you know where you sit within your chronic disease patients as well, and the patient basis that you actually aren't really targeting well. And so there's ways to improve the way your practice becomes, looks at those patients as well. So what I mean is, you'll say, well, your diabetics aren't, you're probably averaging a lot less than local average. Maybe look at targeting them a bit more. The other way that we use population health analysis is, or targeting or engaging our patients, is Facebook. Everyone knows Facebook. This is our think outside the box option. So we do Facebook feeds for all the clinics as well. So we put general information that's publicly available. There's no, obviously, you can't bill your patients for looking at your Facebook pages, but it's a way for us to engage them and get connected with our patients and hopefully improve their health literacy as well. Next slide, please. So how do we use it? Simple. Still, again, publicly available information that we post up. So, for example, on the bottom right-hand corner, the Salisbury Council, which is our local council, runs the Heart Foundation walks in our area. So we help promote it. Top left-hand corner, it's summer season coming up, slip-slop slide, general information. When it was Are You OK Day, we just sent information on Are You OK. This is another way for us to really engage our patients and understand that we're there. We're just giving you general information and help your health literacy as well. Next slide, please. The other way that we engage our patients, and this is about being proactive in the way we engage it, is we've spent a bit of time and effort on our website. All the information on our website we do ourselves. The design, the content, the updates. So it's all internal within our practices. So one of our doctors actually designed this YouTube clip for health risk cup. So the more bad habits that you put into that cup, it starts to overflow. So smoking, overweight. So we designed that YouTube clip and put it up on our website. So it's a way for our patients to go there, get more information as well. Next slide, please. So we talked about different tools that we use. Now that we have these different tools, how do we gel it into our team? And this is talking about the multidisciplinary teams, looking at our nurses, our allied health, front desk staff, our patients, and the greater community. Next slide. So let's look at our nurses. So it's about the coordinated care that they deliver within our practices. So one of our things that we teach our nurses is how to use the doctor's control panel. And every clinical meeting that we run, we spend about 5 minutes on PenCS and doctor's control panel. So knowing that they could understand the different tools that are available within doctor's control panel to use on their day-to-day work. So we teach them on how to identify the risks, look for BMR quickly, if the away needs to update it, they do that as well. And we also say, well, if they've got a care plan in place, you could build a 10997 for those patients, or an active health check, build a 10987. And a lot of those item numbers are really underutilized within general practice. The other way that we get our nurses involved is making sure that they target different chronic conditions or different sets of our patient base. So all asthmatics, we encourage them to have a spiral annually. For women that have were pregnant previously or have gestational diabetes, we encourage them to have a talk about weight management and glucose tolerance testing. So for our diabetics, we get our nurses to discuss with the patients. The guidelines say that an ECG should be done every 12 months for all diabetics. So this is about systematic and proactive care. So within our clinics, we've developed a model over the years so that all the nurses and doctors understand a consistent, systematic process that we deliver for our care to our patients. What do I mean by this? So it's a cycle. For care plans within our practices, if they come in today's day naught, they'll get a care plan done, a team care arrangement, we'll bill a 10997 for the nurse's time. Then the patients know that in 3 to 4 months, they might come back for another visit. It's flu season, they might have a flu jab done, and the nurses could charge a 10997 at that time. A couple of months later, the patients know that they'll have to do a review for both GPNP or TCA to see where they're at. And sometimes patients may not have used any of their TCAs, but still good to do a review because this is a way of being proactive, helping them with their health literacy, helping them motivate to make those changes in their lives as well. So then once the review is done, you charge the 10997, the patients know that you are looking after them and you do care about them making changes in their life. So they come back another 3 to 4 months later, then you could add all the items for, say, for example, diabetes SIPs are undertaken, then you could do an ECG, charge a nurse item number, and the cycle continues again. This same model we've kept for most of our chronic conditions as well. Okay, so next slide, please. So we could apply this model so that everyone within our practices understands the same similar approach for most of our patients. So for an ASTI patient with the ASTI health check, we know that we keep a similar time frame. So again, at day naught, they might have an ASTI health check done today. They might come in 3 months' time, have a flu jab, charge a 10987. 6 months later, they might have the asthmatics, do an do a spiral, do all the items for an asthma SIP, charge a 10987. Then they come in just for general checkup or general checkup with the nurse itself. Then you can charge a 10987 as well. And you know, with an ASTI health check, that you could have up to 10 nurse visits as well. Next slide, please. So this is just a bit of information that we got from the Medicare slide there. That you know that Medicare says that you have the opportunity to use these item numbers, and so from a practice point of view, we've integrated that into preventative measures as well, into proactive care, and so that we'll better be able to, I guess, keep on top of things as much as possible with our patients. We do, one of my first slides is we do have a younger population. So within our practice patient base, we have to do a lot more preventative measures than most than other practices with a higher age demographics. So the next slide is on allied health. So how do we get our allied health team working within our practice? So over our journey through the primary care collaboratives, we understood that they really needed to be on site. The reason being is there's that feedback loop within the allied health team, our front desk, our nurses, and our GPs as well. It's that interaction that becomes integral to delivering better care from our point of view. Our allied health also get involved with our weight clinic as well. So they actually donate their time to come and do the presentations for our weight clinic. So over our journey, we've added all these allied health within our practice. And I'm going to spend a couple of slides on one of them, which is the lifestyle advisor. Next slide, please. There's not many people know what a lifestyle advisor does or how they can help within general practice. So Miguel's our lifestyle advisor in our practice and has been with us for six years or so. He's also a social worker, so he understands the mental health side of obesity. So one of the things that he talks about with the patients is where they're at in their life cycle, all right, in their weight loss program. And then he talks about certain things about social support or social isolation, reducing fat or taking a more high energy diet, talk about lesser activity and simple exercises that will cater to which part of that weight loss journey they're in. And so then he talks them and coaches them through that process, taking this into effect their mental condition as well. Next slide, please. Because he knows that lifestyle changes can cause inadequate sleep. All right. So one of the things he talks with these patients, and he really spends a lot of time, is the factors that affect sleep loss. So studies have shown that sleep loss can lead to other chronic conditions. So he talks about obesity, smoking and alcohol, stress and anxiety lead to sleep loss, and then the consequences of that is other chronic conditions like heart disease and diabetes and fatigue. Next slide, please. So you understand how the allied health team now becomes part of our wider team. Then we talk about our front desk staff, our reception and admin team. They become our gatekeepers. So within all your practices, they're one of your key people. They listen to all the patients, they book them appropriately, they become your front line. So from our front desk staff, we get them to help identify patients that have incomplete information in terms of their health assessments, chronic disease, or SNAP, so then they could book them accordingly. We train our staff on how to use the doctor's control panel, and therefore they're better able to understand how a patient can be seen by a nurse and where the nurse can help as well. So then they could direct those appointments appropriately and direct that patient to a nurse before a doctor's appointment. The other way we do get our help from our front desk is updating their social and family history. And I'll show you what the yellow sheets I mean by that. Another thing is they could identify patients to book in the 109 and book accordingly. So the other factor that our front desk staff do is actually looking at patients, looking at the way that we could update their data and direct them accordingly to our nurses to update that information, clinical information. Other way we get our team working is looking at our patients. Get our patients to work for you. And so what we do is we get our patients, especially during, say, 3 to 6 months before accreditation, we actually run a data cleansing / data collection exercise, and we call that our yellow sheet. So we give every patient that comes in a sheet that gets automatically printed, sucks out the data from the clinical software and your billing software, so on their demographics, allergies, and a few other information, and we give it to the patient and we tell them, have a look at this information. Is everything correct? Just put a tick next to it. If it's not, could you correct it? So the other factor that we get is the info screen I showed earlier as well, looking at national guidelines on good health as well. Next slide. So this is what I meant by the yellow sheets. So a lot of information, and this is actually a little tool that comes with the doctor's control panel called the reception control panel, which actually sucks out all the data. So the patients that come in, they check in with the front desk, gets automatically printed. So all the reception has to do, you could do it manually or you could automate it. The patient takes that printout, gives it to the patient, so they could update their address, update their contact details. Important thing is updating the emergency contact and next of kin. It's under allergies. You can see on the screen it's got the current allergies that's in our clinical software and any reactions. And on the back of the while you're waiting sheet or the yellow sheets, we print them on yellow sheets, by the way. They could update their smoking and alcohol status, any vaccinations, update their family history, and right at the bottom, it's about nutrition as well. We get them to tell us, how many food they eat daily, how many serves, etc. So we're helping proactively encourage our patients to start thinking about factors that will help them improve their own lifestyle as well. And this data is entered in by our front desk staff. So what are we trying to do here? So we've seen a lot of information come through right now. So most importantly, we want our patients to influence the people around us, our family members, so that they can avoid the chronic conditions that we get later in life. So the idea is making those lifestyle changes now so that you see the benefits later on down the track. Next slide, please. So how are we trying to achieve this? We're also not just doing this within our practices as well. We use our community resources, and a lot of you already have access to a lot of these community resources. So within South Australia, we've got the Get Healthy program. Just go back one slide. We have the Heart Foundation walking program, so we really encourage this within our area for our patients to undertake as well. Next slide. So what are we trying to achieve from all this information as well? We're trying to we're actually freeing up the doctor's time. We're letting the doctors do what only the doctors can do, and that's looking after people's chronic and acute conditions. We're letting our nurses and our front desk staff deal with a lot of the paperwork, a lot of the clinical tasks that they can do. Next slide. You know what? There is no perfect time to make these changes, and we realize that the only way to make these changes is just to start making them from day one. All right? So you will never find that perfect condition to get things done. So the idea is, if you see a piece of work, try and start with a manageable piece of work, and this is what the primary care collaboratives have taught us. Look for a small piece of work, identified, but you must be able to measure the change that you undertake with that small piece of work. And once you do one, you do another, and it's snowball effects. And that's what's happened with our practice as well. Next slide, please. So I'm going to quickly talk about the medical home. So you can see the GP becomes a conduit for the patient. But a lot of the help for our patients happens in their own home. And so if we are better able to educate our patients, improve their health literacy, they're better able to look after themselves and the people around them. Next slide. And this slide's about our field of influence. Within general practice and primary care, we could help motivate and help make those changes around exercise, smoking, alcohol, lifestyle changes, lifestyle modification. Right? So those are our fields of influence. And next slide. Oh, we go back one. So what's all these lifestyle changes these changes that we can impact? Our areas of influence. They all relate to the the RCGP guidelines around SNAP, smoking, alcohol, nutrition, and physical activity. So that's what the change that we can make within our practices to our patients as well. And there's the RCGP SNAP guidelines. You can download, I think it's free from their website. Next slide, please. So we've done all this work. We've done these changes within our practices. We must be able to quantify those changes. And this is what the next few slides are about. All right? So we could see that over that time, when we started the journey, and this looking at the last 5 years worth of data, that we could measure and track if we're making an improvement. All right? So in this graph, we just looked at allergies, smokers, alcohol, blood pressures, BMIs, and waste. Next slide, please. Oh, back one. Okay, cool. So we could see that with our smokers in the middle, that the number of smokers has reduced over that time. On the right-hand side, the number of waste people with a normal waist has increased over that time. On the far right, the BMI less than 25. So patients with BMIs less than 25 has increased over time. So we're making a difference. And in our own way, we're transforming the health of our local community and our patient population as well. Next slide. And that's it. Thank you very much. I hope you enjoyed that presentation. Do you have any questions? We'll have a few minutes to do.
Thank you so much, Prashiba. And that's a lot of information, but some really wonderful pieces of work that you've done, and you've demonstrated the improvement and also some really innovative ideas, particularly around the use of making sure that your patients work for you as part of the team, and also your use of technology. There were no questions as you were presenting, but I'm just going to give everyone another minute or two either to raise your hand or to type a question into the chat pane. And we've got nothing coming through at the moment. So I'd really like to thank Prashiba for sharing all of those experiences with us, and as I say, demonstrating some of the outcomes. Oh, excuse me, I don't know what happened there. I apologize. Let me go back to the slides. Here we go. Sorry, and now I think we may have a question. Let me just bear with me. Kylie, I believe, would like to ask a question, so I'm just going to unmute Kylie. Hi, Kylie, are you there?
Yeah, I'm Kylie, and this is Penny here with me as well. And Penny's got a question.
Great, fire away.
We live in remote Queensland, just sort of starting out care planning and feeling as though we are making a difference in our small community. Fantastic presentation. We're wondering if it's possible to get a copy of your PowerPoint, and if you would be interested in discussing it further with us over the phone so that we can get some assistance from you.
Yeah, absolutely. I think Katie's got a copy of our presentation, and one of the things I learned through the APCC is share generously and steal shamelessly. So I do make all my presentations available for the Improvement Foundation to share with anyone. So absolutely, and yeah absolutely. Katie has my contact details as well, so she she'll be more than happy for me to get her to pass on my contact details and get in touch and talk to your practice. Absolutely.
Thank you. We were looking at it as a mentoring type process.
That's right. So one of the things that I didn't talk about here is we run our own Practice Managers Network group in Northern Adelaide. So over the years, you get to know each other, you know each other's practices, and share your ideas and your learning, so that one of the keys that we as practice managers and nurses and staff within practice, we work within our own four walls, yet we don't know what else is out there. And the only way to do that is go out and talk to other practice in the area. And you find that sometimes when you do hit a brick wall, do hit a problem, it's actually, if you talk to the practice nearby, they're actually probably already had that problem, found a solution, and a way to overcome it as well. And most of them are happy to share it.
Terrific. Thank you. So just to let you know, I will be sending out the slides to everyone after this webinar, so you will have a copy of Prashiva's work. And Kylie, I will make sure I get Prashiva's contact details to you. We have one more question from Michael. I'm just going to unmute Michael. Michael, I think you may have muted yourself.
I'm unmuted now, I think.
Thanks, Michael.
Yeah, I just wanted to know, thank you, that was really interesting. I only got half of it due to technological problems at my end, but just wondering if you had any resistance from staff in terms of perception of extra workload for the practice doing this.
There's always resistance to change within our practices,
yep.
And we did have that through our journeys. And one of the things that I do like to say is, it's not always been plain sailing. It's a lot of hard work that goes with it, time. And sometimes the idea is you try and take all the staff with you along that journey. And yep. I always say sometimes there are casualties along the way. Right?
Yeah, okay.
But from a practice and your patients and the overall practice staff point of view, it's actually making their life easier if they understand that they're all working towards the same goal, and the same amount of effort that they put in to helping their patients will make a difference. And so therefore, it, in a way, lifts the other staff within our practice as well. They know that they are all working to that one direction and one point. So that's,
sure.
You do get casualties along the way, and that's happened with change, where sometimes they're not ready for that change to happen with their practice, and we'll have that in the past as well.
Great, thank you very much.
Thanks for the question, Michael. And just to add to what Prashiva is saying, over the years through the APCC program, we found a number of ways to address those issues. First of all, it's quite helpful to start with a small team of those who are engaged with change. It may not be necessary to have everyone involved in the change effort at the beginning, particularly those who are resistant. I guess it's about return on investment with energy. Another helpful thing is with measuring and displaying data, people often change their mind and become a little bit more interested when they can see the results of the change effort. So it may be worth starting with a few people who are interested and then demonstrating the progress through the use of data, and hopefully you'll find people are less resistant.
And could I add to that, for Michael, the way that we display that data is we actually put it on a whiteboard in our tea room. So we'll print out those graphs from Pen CS and before and after, and just put it in the tea room, so that next time that they're having their lunch or coffee, they could see right there on the whiteboard.
Thank you. I can't see any more questions either on the chat pane or anyone else's hands raised. So I'd really like to thank Prashiva for today's presentation. Lots to take in, but really useful information and loads of innovative ideas. And I'd like to thank all of you for attending today's session. We have one more webinar in the series of 5, which will be next Tuesday at the same time. That's Ros Rolleston, who is primary healthcare nurse and educator from Nowra, and she has a wealth of experience in the acute and primary care sectors and is just about to finish her Master of Nursing. Earlier this year, Ros began a new role as the Skip into Life project manager at Warragee Medical Centre, which was a specific nurse clinic for people with mental illness. And Ros will take you through the journey of establishing that nurse clinic and what are the key factors to make nurse clinics successful, not only from a patient point of view, but also from a practice point of view. So if you're able to join us next week, that would be terrific. If you'd like to register or you'd like to recommend this to your colleagues, please go to the Improvement Foundation website, improve.org.au, and register there. And I would like to thank SA Health, who are the funders for this particular webinar series, and acknowledge that it's their generosity that has enabled us to have speakers of Proshiva's calibre. So thank you everyone for your attendance, and have a good afternoon.